That quieted the audience. It was just a sound check, but we might as well start. It's 8:01, right? I've got the thumbs up from Joe. Thank you very much. So good morning, everyone. Bonjour à tous et à toutes. As guests, I would like to begin by stating that the Future of Health and Wellness series event is taking place on the traditional unceded, unsurrendered territory of the Anishinaabe Algonquin people. As guests, we are honored to gather here today, and we give thanks to all the generations of Anishinaabe Algonquin people who have and continue to take care of this beautiful land. The trees to give us shade, water and food to sustain us, and path to connect us. Algonquin College recognizes and appreciates their historic connection to this place, and we also value the contribution that all First Nation, Métis, and Inuit people have made and continue to make in shaping and strengthening our community. Thank you. So my name is Claude Brûlé. I'm the president and CEO of Algonquin College, and it's my distinct pleasure to host you for another session of Future of Health and Wellness Speaker Series. We have been doing these sessions since 2016, so 7 years that we've been doing these sessions, and this is the first time that we cover the topic of dental, oral healthcare, dentistry, and public health related to dentistry. So we are pleased to be offering this in hybrid modality this morning for everyone's comfort. So we have a live audience here today with a nice light breakfast. And we also have an online audience who can see and hear us, but we cannot see or hear you. So welcome to our online audience and welcome to all of you here this morning. I would like to also take the opportunity to share the hashtags that we have for you to continue to have this conversation online as you so wish. So we have two social media handles. One is hashtag ACHLE and hashtag ONHealth. So this event continues to be the place to have conversation around health. These conversations matter to us, to our community. They're of relevance to the future of health and wellness, as we all know. So before I go any further, I'd like to acknowledge the presence of community stakeholders who have joined us today. So online, we have Stéphane Sarrazin, who's the MPP from Glengarry Prescott Russell. So good morning to you. Joining us in person, we have Dr. Vera Etches from OPH. Welcome, Dr. Etches. We have a number of our Board of Governors who are here this morning, starting with Dr. Gail Beck, our board chair. Stephen Tudor is here. Good morning. Audrey Lawrence is here. Good morning. And Valerie Saya, good morning to you. You made it. That's great. So thank you for joining us this morning, and a special thank you to our two sponsors and partner for this particular event, of course, Ottawa Public Health, as well as the Canadian Dental Association for their contributions to partnering on this particular event. So with us today, we have one guest here in person in the audience, and we have two of our guests who are here online with us. So I'll start with Dr. Keith De Silva, who's the president of the Canadian Association of Public Health Dentistry, and he's an assistant professor of dental public health and pediatric dentistry at the University of Saskatchewan, where it's 6 in the morning. So welcome to you this morning. We have here, I almost said in the studio, in Wapen here, Jenny Gardipi. She's a senior policy analyst for non-insured health benefits with the Assembly of First Nation. And she's also from Saskatoon, and she came in person today. Thank you very much for being here with us. And Emily King, who's a navigator for non-insured health benefit with the Assembly of First Nation, and Jordan's principal liaison. Welcome, Emily. Dr. Lynn Tompkins, president of the Canadian Dental Association, who was going to be our fourth panelist, unfortunately could not join us this morning. The CDA has been trying to get a meeting on the Hill, and they have one this morning with the Prime Minister's office. So yeah, I guess that takes precedence. So she won't be joining us this morning. And so speaking of, this morning's discussion will tackle the topic of federal government's consideration of implementing a new dental care program. We've gathered this special panel to have this thoughtful discussion on the future of dental care in Canada and highlighted the importance of public health dentistry in dental care. So let's get started. As you all know, in 2022, the federal government announced plans to create a Canadian dental care plan. And in the most recent federal budget 2023, a Made in Canada plan was announced with an estimated cost of $13 billion. That's a B, $13 billion over 5 years. So the big question, I guess, other than the obvious political consideration here is, why is oral health care becoming so important to get national attention? And why now? So perhaps I will ask Dr. Silva here to start us off with that question.
Sure. Can everyone hear me?
Yes, we can.
Wonderful. So I'll first acknowledge that I'm calling in from Saskatoon, which is on Treaty 6 territory and homeland of the Métis. Also very early at 6 in the morning, and it may snow this afternoon. So that's Saskatoon in a nutshell for us right now. So, obviously I'm a little biased, and that oral health has always been important, but there has been a lot more discussion over the last 5 years, I would say, and even more so in the last year or two, particularly at the national level, and a few different reasons. One of the main ones being just access to more data. So in 2009, 2010, we had the Canadian Health Measure Survey, which had an oral health component. So that was kind of the first national data set or national estimate of oral health that had been done in close to 30 years. So with that new data, a better understanding of not just the burden of oral health disease across the country, but the inequities that were in our system. And that became a powerful tool for advocacy. And over time and with existing research, you see a lot of that data being presented to decision makers, and it's been having a kind of a cumulative impact over time. The other kind of issue that related to data is just more research on the importance of oral health as it relates to our general health. And so, we've long kind of had a separate healthcare system that separates the two, but understanding the connections to, not having a healthy mouth and how it relates to other systems in our general health has really made an impact, I think. And so more people outside of healthcare are starting to notice some of those relationships, and it's really having an impact on the political side of things.
Thank you, Dr. De Silva. Jenny, same question from your perspective.
From speaking with non-insured health benefits navigators, they work directly in the communities, and they work all across Canada, and they work directly with populations that have high risk for health disease and especially oral health. So having access to healthcare, dental care, I think was a big issue, especially with non-insured navigators. The main priority access challenge is dental healthcare. So when you said why now, we were yelling why now back, years ago. So I think, we want to make sure the message is clear that First Nations health shouldn't be left behind. Everybody should have equitable health care, especially, First Nations communities. A lot of the health disparities, they're like very high and all across the board. So I think having access to healthcare, dental healthcare is really vital. Equitable healthcare, like Dr. De Silva said.
Thank you, Jenny. And Emily, as a navigator, and what are you seeing on the ground that would answer that question, why now, from your perspective?
Well, there's a lot of things to be said about oral health care and also dental health benefits, which is provided by Indigenous Services through their uninsured benefits program. for a long time, First Nations have dealt with the lack of proper healthcare, oral health care in the communities. A lot of communities are underserviced, are unable to access the right treatment, and also even having dental providers coming into the communities to provide the care. Children, adults, seniors has been a long-standing issue, and as Jenny said, it has been brought up, it has something that has received national attention over now and then. And sometimes there might be some spotlight on those issues and then it'll disappear. And that goes with the same with orthodontic, which is very hard to access for Indigenous peoples. And so I think why now? We hope, we're crossing our fingers. We're a bit skeptical, but we're keeping our fingers crossed that this is a time that real change will come to Indigenous oral health care.
Thank you, Emily. And certainly, having had a minority government propped up by an NDP party has really contributed to accelerating, if you wish, the start of this program. But fundamentally, this framework has been predominantly provincial in nature with private and public service delivery. And what's being proposed is a national delivery program with more public community-based provider. So what is, in your view, I guess, the main challenges and barriers to the existing system? So I know we've started a little bit there. We've heard a couple of things, but what are the main challenges to the existing system and what needs to be thought about to deliver on the promises of the new program? Maybe I'll start with you, Jenny.
Yeah. I meet with the non-insured health benefits navigators regularly, and a lot of the challenges, I guess, they mention is like pre-approvals, preventative care. If you want to have, equitable healthcare, then I think having easy, streamlined methods, processes that are not so administrative burdens. I think that was one of the challenges, especially as a service provider. Like they talk to our community members, they talk to our non-insured health benefits navigators, and they mentioned that the administrative burden is so cumbersome when it comes to non-insured health benefits, having to send in for appeals, having to, request for, anything like pre-approvals, especially with dentistry, and also a huge access is in the northern and remote and isolated communities. Those, especially with COVID, one of our navigators mentioned that they haven't seen the dentist hasn't come into their community for 2 years because of COVID. And then so you can imagine the backlog. And then with 1 or 2 dentists coming into the community sporadically, creates like such a, and then sometimes the community members have to go fly out to Edmonton or other other urban centers. And, even that is more expensive, right? So when you overall, if they're always concerned about, saving money, I think preventative care is such a huge win-win, right? So having access to preventative care, less administrative burden, I think is such a big, one of the main things, one of the recommendations I think navigators recommend. Sorry, and culturally safe care. A lot of community members come in and they mention that there's a lot of stigma, discrimination, racism that comes in. So accessing healthcare, accessing culturally safe healthcare, trauma-informed healthcare is so imperative. A lot of the community members we don't want a one-size-fits-all for cultural safety. I get a lot of questions like what program would be good, what method would be good. And our navigators mentioned that Why don't they make it region specific, local specific? Why don't they come in to communities and see how we actually operate, how we actually live? Instead of getting a check mark, yes, I completed my cultural safety. You know, go into the communities, that the people that you're serving, the people that you are dedicated to helping, go into the communities, spend some time with the people and get to know them. You know, then that just opens up so much doors, and you know, it just creates that relationship, that trust, because like Emily had mentioned, we're crossing our fingers, but still we've been down this road before, right? So we want to make sure that we don't get left behind, that all the care is trauma informed and culturally safe.
Very, very important consideration, and to make it regional, I think will make all the difference. Yeah, thank you, Jenny. Maybe I can go to Dr. De Silva with that same question around what are the challenges and barriers you're seeing in the existing system, and what do we need to think about as we embark on this new program, given the provincial, federal jurisdiction barriers?
Yeah, I mean, to start, I think it's quite a transformational change to see this degree of federal involvement in dental care, which is traditionally a provincial aspect. So, you know, we applaud that decision by the federal government. I think in terms of challenges to the existing system, you know, the obvious and the largest one is cost. If you're uninsured or don't have the means to pay for dental care, you are left without access, and that's affecting way too many Canadians, particularly those in northern regions or those in kind of specific low-income communities that we need to address. And so that divide has gotten wider, we'll say, in terms of being able to afford dental care, where it's almost a luxury for many Canadians. And so, you know, the magnitude of the federal investment, you know, will help make a dent in that to a degree, but there are still many other challenges that will kind of remain. The next biggest one is probably just based on geographic location. So, you know, if you have access to insurance but don't have access to a dentist in your community, particularly in areas the further north you go in Canada, you're still left with challenges in getting the care that you need. And so we'll need to be creative in how we address that. You know, personally and professionally in dental public health, we believe in seeing a greater contribution in community-based dental clinics or publicly delivered dental clinics to help bridge the gap. But it's going to, again, have to be kind of regionally specific in terms of how best to meet the needs of areas which are typically underserved. And then I think one other challenge we also see, it just kind of relates to how we accommodate patients. So I'll talk specifically about, you know, one of the main target areas through the federal dental plan for individuals with special healthcare needs or disabilities, where again, they may not have access to specific facilities that can accommodate them, which could be hospital-based or with specific accommodations within a dental office that a plan itself won't address. And so there needs to be, you know, additional training for specialized training for dentists and dental healthcare providers, as well as other physical modifications to dental practice that can accommodate them. And so again, beyond just the dollar amount that's being invested, we really need to think about how the plan will end up, what services will be covered, and how that will be distributed. Because, you know, as was noted, a plan for children is going to have to be different than a plan for adults, which will also be different than a plan for seniors and so forth. And so you really need you know, to be creative with a customized approach to really make sure everyone can access what they need, with a big emphasis on prevention, which is sorely missing from a lot of programs.
So how Dr. So if I can ask a follow-up question then. So how is the policies being influenced, if you wish, to achieve what you just spoke about, some of those regional differences that are needed in the system, as well as different population needs? How will this be addressed in affecting the policies that are being developed?
So I think, you know, at least what's been you know, somewhat exciting and, you know, gives me a great sense of optimism is that At this stage, the federal government is really engaging with the profession and the public in terms of what's missing from existing plans and how best to improve it. So they're consulting a wide range of professional bodies, advocacy groups to gather that information, trying to learn from previous challenges with provincial programs or other public programs. How they're designed, the administrative burden in terms of receiving claims, both for dental offices as well as patients, tends to be a barrier that is being brought to attention, as was mentioned earlier. And so, hopefully by collecting this information, it implies that it will be at least attempted to be implemented, across the programs.
Thank you. Emily, I want to pick up on something that Jenny mentioned around cultural safety in receiving care from provider. And do you have an example of something that has worked well in community, perhaps that you can share with the group that gives us hope for how we can improve the system to make this more widespread?
I think so in terms of a successful dental practice in a community, as we know, there's no, that we know of anyways, of dental practice on reserves. Normally then reserves have to kind of import services from dental services that are located in urban areas. And so also for that to happen, we also encounter competition per se. A lot of dental practices tend to be located in large urban centers. They're set up with hosted with other dental providers, and they service their locality per se. And sometimes it takes somebody, a dental provider who has practice, say in a small town, who's willing to go into a community to provide that service. And so that has been very challenging. Not many providers will provide, do that, be able to travel over time, months, years, and be that community dentist. There has been a few times in the past in the communities where they have been able to have a good relationship with a dentist. But cost has been a factor, transportation is a factor, payments and compensating the dentist, the dental provider is also a factor. So aside from that, those are kind of the things operationally that may inhibit a good community relationship, and also for the community to be able to receive appropriate dental services. However, what we find also, particularly in large centers in Toronto, so there's the larger GTA area, if a dentist has a practice, say in downtown Toronto, the chances of having a First Nation patient come in is very rare. So their offices are not equipped or to respond to the needs of a First Nation patient. And Dr. De Silva mentioned that, they have to be there has to be accommodations made in the dental practices. And I think, that would go a long way to make it more culturally appropriate, is making those accommodations. And sometimes time is of essence. And sometimes many practices don't have that time. And also they're running their offices, they're administering their offices, and encountering a First Nation patient with dental care who may have not had dental care for a while. And there's a process to follow that Jenny described to seek approval through non-insured benefits, which also is another challenging area. So sometimes the priorities is not there for First Nations care to be fully provided to. So there are many challenges in terms of customer services too. And so First Nations have status cards, which they present at a dental office. And sometimes that status card, there could be some perception around the status card as well. So there has to be some education around that as part of that accommodation.
No, thank you very much, Emily. That's a great question to be addressed. And being in an education institution, I think there are opportunities for all institutions that provide dentistry, dental assistance, dental hygiene to contribute to that solution. I know we have some faculty in the room here today and a chair of a department here who's nodding back there. Maybe we have time for a couple of questions from the audience, and maybe that would be a good time right now to open the mics for our audience. If you have a question to our panelists, especially as we talk about cultural sensitivity, creating a safe environment for all patients to receive equitable care in our Canadian society. Here's your chance to ask a question. Dr. Etches.
Yes, I couldn't help but want to speak up as you were describing the challenge in urban settings here in Ottawa, just to let people know that the Wabano Center has a dental clinic that is open for First Nations, Inuit, Métis, people who don't have status cards, people who have status cards, and it's a partnership with Ottawa Public Health, and it's providing that dental care in an environment that's already welcoming, that's visually, is something that people can connect to and know that this is a source of support. And so I think there are models that could be publicly run clinics in urban centers. I think I'm curious about whether you said, Dr. De Silva, that is a way to fill the gap. I wonder if there's a way for urban centers to have extensions or connections out to First Nations communities as well. If there's any discussion of the cost that would be involved, as you mentioned, Emily, or I think Jenny, the barriers to that travel being there's no fee in the dental schedule for that kind of effort.
Yeah, so I mean, I think, where there's a will, there's a way. And so you need motivated people within communities to help start making those connections. And again, every model is going to be a little different on how to effectively do this because every community is different. And I think trying to bridge the gap between urban centers and some of the more remote regions is necessary and something that we have to further develop. We have some examples here in Saskatchewan where in partnership with our teaching clinics, we have kind of remote satellite locations where we can have a presence within some of the northern communities and provide services, as well as training opportunities where our students can get to see what practicing in the northern areas could be like and how rewarding it can be. There are similar community-based programs I know to our neighbors in Manitoba. Still few and far between, but there are examples where this can work.
Go ahead, Jenny.
Yeah, and I'd like to mention to tail on to that is some communities, some First Nation communities have dental hygienists right in their communities. So they work directly with the youth, with children in school, the babies. They have different programs that non-insured health benefits provides. Also, I can't remember. It's an acronym called COHI. I don't remember what it's infant health. And
the Children's Oral Health Initiative.
Yes, that one. And so they work directly with the dental hygienists. So they provide preventative care directly within communities. The dental hygienist is hired and by the community, and they work with the community.
And do they reside in the community or they travel to?
It depends. Sometimes they're community members that are dental hygienists, so they work right with their communities, but oftentimes they work, they travel in.
Okay. Thank you. Thank you both for your answers. Oh, we have a question here.
Good morning. Thank you all for your presentation. It's great. Just out of interest, we actually have a faculty member who works for Cohi with Health Canada here in Ontario. So we get good information from her. Recently, I had 2 representatives from Health Canada come in to speak to our dental hygiene class, and they work specifically with the Sioux Lookout in Ontario. But they spoke about Jordan's principle, and I was just wondering, I think Emily in the intro, Claude said that you work with or you
She's a liaison. Yes.
liaison. So I'm just wondering if you could speak a little bit about that, because I just recently learned about that, and I think it's really a wonderful thing.
Yeah, sure. Yeah, so I'm located in Northern Ontario, and I'm very familiar with Sioux Lookout, and having I worked with many organizations in that area that provide services to remote First Nations. And so generally a lot of times pediatric dentistry is a challenging area as well. A lot of children needing oral health care, and generally just basic examinations like before school and all that. And also in many cases, many children in the Sioux Lookout area, well, they run a dental clinic. I believe the organization that that provides that service that you were that they mentioned was the Sioux Lookout First Nations Health Authority. So they do run a dental clinic with non-insured health benefits, and also they have a relationship also with the Sioux Lookout Minnehaha Hospital to provide some dental clinics in hospital. A lot of times, one of the things that is very an issue is children having to come out to the hospital, have surgery, go under anesthesia, and have teeth removed. And again, that has to do, but that has to do because of the lack of oral health care and children. And even like teaching, I guess, children, and also making sure that, school children have the dental care they need. We also know that there is an issue with the water in many communities. Oral health is a challenge, and that's also related to water issues. We hear of the lack of the cleaning and also the water advisors across the country. And we also know that that plays a part, and there's a connection between oral health care, such as other illnesses such as diabetes, and that impacts good teeth. So hence that overall the well-being is impacted when there's a lack of oral health care. And we see that many times and many children, adults. So in terms of Jordan's principle has been able to assist children to bridge get those needs met. A lot of times NIHB does has some provisions around preventive care, but because there might be the need may be higher than normal as opposed to mainstream child. For instance, a child needing to go for extra scalings, extra units, extra anesthesia, sedation. Those may not be covered by NIHB, and in those instances, that's when Jordan's principle will come in and cover those. As well, children 18 and under are eligible for braces. However, the criteria to meet those, orthodontic treatment under NIHB is very, the threshold is very high, and children sometimes will not get braces until until, well, a lot of them go through their life without having that treatment. And when Jordan's principle came in, it allowed children to access braces much earlier, and also while they're in their teenage years. Hopefully that answers some of your questions.
It does, Emily. Yes. Thank you very much. I think we have a question back there, and then Audrey here has a question as well in the front. So go ahead.
Thanks, Claude. Just to echo Dr. Vera Etches's comments, we also have a student dental clinic that supports individuals from our community who may not otherwise have access to dental care. So I want to put that plug in, but
Thank you.
but a question, I guess, for the panelists. So recognizing some of the cultural barriers that individuals face when they go into a clinic is something that we've seen and that we've recognized within our dental assisting and dental hygiene programs for a number of years. And I think there have been a number of concerted efforts to embed within our curriculum cultural awareness and indigenization of the material. And I know that historically we have, through Zoom, worked with northern communities in the elementary schools with our students, talking directly to those elementary students just about good oral hygiene. But I guess my question is, and to any of the panelists, but how can we build this within, because I think, how do we build this within our curriculum? Because I think when you give a student or a new dental hygienist or a dental assistant that foundational knowledge from day one, you really prepare them for success in how they welcome new clients to their offices. So just looking for perhaps some tips and perhaps future collaboration in how we can build that capacity and make it truly accessible for all of our clients.
Okay, who wants to take that question from Aaron?
Sure, I can start. Somewhat biased being in academia now, but when I transitioned from private practice to a full-time university position, one of the first things I learned is that curriculum change itself is a beast of a topic with many challenges to it, and so I agree with you that cultural safety and cultural competency needs to be part of a curriculum from day one and kind of embedded throughout the curriculum. It can't just be a standalone course that you take at one point and then never use or practice again. And so there's been talks about national standards in terms of licensing for cultural safety, but that has to be kind of one arm of many different resources available for it. But it includes experiential learning and working within communities where possible, as well as integrating the material into many different courses as opposed to just a single kind of entry in year 1 or year 4 at the entry or exit points in any of the programs. And so I think we're moving in the right direction, albeit slowly, but it really does have to kind of take a coordinated effort from not just the educators, but the regulatory authorities, as well as community members on how best to implement this and then translate that into actual practice.
So we will, it's a journey is what you're saying, basically. All right, any other panelists want to add to this? If not, we'll go. We have a couple more questions, then I have a final question to all the panelists that I really want to get to. So we'll, Audrey, go ahead.
Hi, honey. I'm very pleased with the work that you're doing, and I commend all the speakers. I just want to give a little historical note because Claude started off with saying what has changed. When I was 19 years old, and I'm over 70 now, I was teaching in Rouyn-Noranda, my first class, and half the students were from the town. The other half of the class were Cree children brought down from James Bay because at that time they didn't have high school. In the month of September, all of a sudden I get a note, a dentist is going to come in to give care to the children from James Bay. So it's fine. I was told to clean up the art room, to set it up. Dentist came in. I sent one little girl in to get her teeth looked at. She came back and she was bleeding, and he just sent her back into the classroom. No care. I called the principal and I said, I am not sending another child to this person. He took out 7 teeth without anesthetic. And anyhow, we had a kerfuffle. The next day, representatives from Indian and Northern Affairs came up, which was at the time, to lambaste what I had interfered with. And so from that time, they set up a special arrangement. And of course, me being very young and ignorant, I kept saying, well, why can't they go to the dentist in town? What's the barriers? What's the problem? These other kids go, these people are here, they should be able to go. So these issues are more than long-standing, they're continuing. But it set me off on a crusade to be a very activist around policy. I helped to implement bringing in the standards for cultural safety for the schools of nursing in Canada, which the doctors, the Indigenous doctors had already started. So getting, as everyone said, getting those standards in, getting them as practice right from the school, right from the get-go, and keep with the pressure. That's all I can say. Thank you, Miigwech, for your work.
Thank you very much, Audrey, for your words of encouragement and for your crusade over the years. As I said, it's a journey, and it's about relationship as well. I think in talking with the panelists in our prep meeting before the event, we talked about not just checking boxes, the importance of really forming relationships with the communities, so vital. So the work that all institutions can do, that train our dental hygienists, our dental assistants, is promote that going to the communities and really making a difference there. The final question I have is related in part to the pandemic. Everyone understands and has experienced to some degree the impact of COVID-19 on the health human resources. And we know what happened early on in the pandemic, in particular around personal support workers, practical nurses and doctors. And the shortage and people who left the field to do other things because of burnout. Are we seeing a similar staffing impact in the dental sector? So anybody who wants to start on that? Maybe I'll start with Dr. De Silva, sorry.
Yeah, sure. So it's, like all things, the pandemic has revealed kind of a lot to us. So I think we've had challenges as it relates to the distribution of resources across Canada in terms of where providers were located that we talked about earlier. But emerging from the pandemic, we have seen more shortages as it relates to dental assistants, dental hygienists being able to work in dental offices, which has definitely been a challenge for the system in terms of being able to provide the level of care. I will say that during the pandemic, most dental offices were very resilient when you consider the nature of aerosols, the additional infection control, and the cost associated with that to adapt and to rapidly adapt. They did so very confidently, and were still able to deliver care without as many interruptions as was seen throughout the healthcare system. But we have a lot of recovering and building back to do across healthcare, both with physicians, nurses, and in oral healthcare. And so again, it's considering ways to kind of increase recruitment. So that comes through education and supporting students. Tuition is rising for all levels of providers, and finding strategies for that. Ways to improve mobility across provinces for existing providers so they can perhaps relocate to areas where they're needed. And then again, it's just looking at ways to incentivize all oral healthcare providers into the underserved areas, particularly in the north. Another example of a strategy relates to providers such as dental therapists, which we have a new dental therapy program starting very soon in Saskatchewan, which will be the first in over 10 years to open up in Canada. And so dental therapists are providers, somewhat similar to nurse practitioners, where they can provide a higher level of restorative dental services, and have typically been recruited to work in more underserved areas. So finding ways to deploy, who can provide the necessary treatment where they're needed will help hopefully bring some efficiencies to the system and stretching the available resources so they can provide as much care as possible.
Thank you very much, Dr. De Silva. Jenny?
Yeah, to lead on to that, the dental therapist program that was offered over 10 years ago was successful because it employed, it educated a lot of Indigenous people that were living in Saskatchewan, and they worked, after they graduated, they were able to work within community. So it wasn't very hard, I guess, to, have that cultural safety, cultural trauma-informed care, because like they have the similar backgrounds, but also like investing the money to institutions that have the dental programs to make sure that, the dental therapists, dental hygienists have the knowledge, the understanding, and the compassion to, deliver healthcare within communities, because that's huge, especially when you want to work with communities. You have to make sure that your heart's in the right place. So that's, that's one of the strengths, I think, with having a dental therapist, dental hygienist, dentist, is to have that culturally safe, trauma-informed education.
Very well said. Emily, speaking about what Dr. De Silva just mentioned around, I guess, unequal distribution of the talented oral health care people that we have in Canada, what would be needed to balance this? Are there, I mean, from your perspective, are there incentives? Are there programs that we can put in place to help people go to community and help provide the care there?
So is that question for me, or?
If you have a
Okay.
comment on that, yes.
All right. The unequal distribution, I guess, one of the things that, being from Northern Ontario and also living in a very large geographical area where there's sparse population, there's less opportunities for education. And also dentistry programs are not as available or as accessible. And there would have to be some type of very creative, out of the box thinking to be able to really provide culturally appropriate that fits the North, basically. Something made in the South will not necessarily fit, the context of the Northern Ontario, whether you're remote, rural, or on, underserviced areas. And there's many large pockets of even in small towns that may not have a regular dentist. You may have a dentist that, may be, retiring and nobody to replace that practice. So there has to be some homegrown initiatives and some out of the box thinking to provide those opportunities for populations in those areas. I think would be one of the greatest achievements to do, similar to the Northern Ontario Medicine School for Northern Ontario. There has been some success there. So, I mean, that is one model that is working.
It will take definitely a village to solve this one, but clearly we have perhaps models that have worked in general health that can be duplicated for oral health as well. I think we have time for one final question over here, and then we'll wrap up this morning. Go ahead.
Thank you. I've been chomping at the bit to get in some comments. I'm with Canadian Dental Hygienists Association. My name is Juliana. And certainly just to echo a lot of points that have been made, one of our biggest priorities with these federal investments has been the idea of prevention. And if we think about that at the level of the health system, Dr. De Silva was speaking of some points in terms of data, getting at prevention before oral health care cases show up as pediatric surgeries, show up as missed school days, missed work days, emergency visits, and so on and so forth. And at the individual level, the idea of prevention as early as, parents starting their family, and the idea of oral health throughout the life course is a really important thing, and a real key aspect of the role of the dental hygienist in terms of promoting prevention. And just to weigh in on another conversation about the workforce and geographical challenges and accessibility issues, one of the things that we've been promoting and bringing attention to is the idea of dental hygienist services that are available in less traditional practices. So a growing cohort of the dental hygiene profession has, they've developed their own dental hygiene clinics, mobile practices. So the idea of dental hygienists going into daycares, long-term care homes, mobile practices going up to remote and rural communities is something that we see as a solution and a strategy that we hope to have integrated not only in the federal program and federal investments, but expanded in public programs in different provinces and jurisdictions, and in public health programs. I'll stop there, but I could go on so many other aspects that have been touched. It's been a great conversation. Thank you.
Well, wonderful commentary to end our conversation this morning. I would like to thank Dr. Keith De Silva, Jenny Gardipi, and Emily King for joining us this morning and providing your insights both into the new federal program that has been announced and the hopes that we have for it all, as well as the barriers and challenges of the existing systems that we also need to confront and address as we develop this new program. So challenges, absolutely, but the solutions are there as well. And from the ideas we've heard this morning, certainly there's hope for encouragement that this will become a bit of a shining star in the oral health system, and something that we can all be proud of. It has to be based on equity and cultural safety, as we've heard this morning. So lots of work to be done to roll up our sleeves. I know that people who work in this field, the people who advocate, the policymakers are all determined to make this a shining example, as I said. A lot of money on the table, as we said, $13 billion over 5 years. It's got to be put to good use. And data, I think having data informed, as was mentioned several times this morning, is key to having the evidence to put those dollars to good use for all Canadians. So I want to thank you. I appreciate your time sharing your insights this morning. Thank you for traveling all the way from Saskatoon. Thank you, Dr. De Silva again, and Emily for joining us this morning. So this has given us a lot to think about. And don't forget to floss and brush your teeth as well, because I'm told flossing regularly will add years to your lives. Apparently. So there we go. So this concludes our HLE event this morning. I want to thank our audience, both online and in person, for joining us, starting your day with us. And I look forward to our next community discussion, which we'll announce in due course to come back together again. So thank you. Miigwech. Merci.